Thank you all very much for joining today's session on empowerment in action, shaping the future of adolescent sexual and reproductive health and rights. I want to say a big thank you for making time. Today is Friday, I know, and the week is almost done. We are all exhausted, but this is also a very important event, and I'd like to welcome you all. To our online community, thank you for joining us. Good morning to you, and whatever time zone you are in, I say greetings to you too. Today's event is very dear to most of us, adolescent sexual and reproductive health and rights, and that's why we woke up very early to come here. It focuses on a theme that is absolutely vital, which is the importance of meaningful and inclusive youth engagement in
L'importance
advancing
d'une
SRHR.
implication des jeunes pour faire
We
avancer
all firmly, or I
les
hope
droits
to
sexuels et
believe that we are all
reproductifs.
firmly
Je me crois que nous sommes
in
tous
the believe that young people must have or must be the center of all our efforts, not just as beneficiaries, but as active partners and leaders in shaping the policies and the programs that impact them and influence their behaviors. We also know that when we talk about programming, when we talk about interventions, it's not a one size fits all, and it's not a one person carrying the cross. We need collaboration from ministries of health, government agencies, civil society, and other key stakeholders, especially the young people, especially adolescents, in order to come up with stronger partnerships that would impact far more greater than what we can achieve if we do it all by ourselves. It is especially very important now at a time where we are having shrinking development assistance, and our financing is declining. And then also SRHR programs are being downscaled or in one way or the other decreased around the world. In response, we must work smarter, build synergies, and maximize the value of collective action. And that is why the 4 EU-funded partnerships represented here today are a powerful example of such partnerships. In the past 3 years, they have done tremendous work across 16 countries in Africa with 22 partners. I'm going to pause for an applause because that's very big. All these partners have contributed in producing very high impact practices in ASRHR programming. How have they done that? They've done that through ways such as tailoring services to the diverse and evolving needs of adolescents using evidence-based approaches. They are also expanding access to information through both in and out of school CSC, while also engaging parents, teachers, and communities, and to a large extent also faith-based organizations and faith leaders. And we all know what it means to engage faith leaders within the space of comprehensive sexuality education. They are also tackling social and cultural barriers that restrict young people's access to service and information, and applying a health systems approach to making contraceptive services more available, more friendly, and more responsive to the needs of adolescents. In a nutshell, at the heart of all of this, we have the adolescents, which is meaningful youth engagement. And we are not using meaningful youth engagements just as a checkbox, but a foundation, more like a founding principle on why this program is thriving. Today, we will hear from all the 4 programs. Rutgers, which is Ado Advanced Ensemble, supporting healthy adolescents. Um, from High, will be supporting healthy adolescents and rights protection, which will be mostly referred to as SHARP. My Health, My Rights from Plan Ghana, and then Youth for Health, all of which are achieving impressive results in improving access to ASRH over the last 3 years. All the speakers, or each speaker, will speak on the highlights of their programs or their projects and would also share lessons which we can all learn from. And that after that, we would open the floor for conversation, both for the people online and also with you that's in the room with us. Now, before we get started, I'd like to acknowledge the presence of Dr. Martin Marine Kuku Wotobe, who is the Secretary General of the Ministry of Health in Togo. If you could give us a wave. We also have Anani, and I'm so sorry if I butcher your surname, Ndakayi Saba, Ministry of Health, Burundi. Thank you very much for making time to join us. Now let's get started. Next slide, please. For our first speaker of the day, I would like to introduce you to Mr. Rajat Khosla, who is the Executive Director of the Partnership for Maternal, Newborn, and Child Health, PMNCH. He brings over 20 years of experience in global health with a focus on sexual and reproductive health and rights, gender equality, and health equity. Rajat has worked across research, policy, and advocacy, and has collaborated with major UN agencies such as the UNDP, UNICEF, and UNFPA. He has also held key roles at the World Health Organizations and the United Nations Human Rights Office, contributing to SDG implementation, policy development, and legal analysis in health and humanitarian context. I think if I'm going to keep talking about the amazing work and the amazing experience of Mr. Rajat, 2 hours will not be enough, and we still have to go home. Some people have flights to catch. So with that said, I'd like to request that you give a big round of applause for Mr. Rajat. Mr. Rajat, your audience.
Thank you for that, Sharifa. And it is rather overwhelming to see yourself on the screen like that. Can somebody please take that off so that I don't embarrass myself any further? Good morning, everyone, and thank you. Thank you really to all of you for joining us this morning. And it is indeed a great pleasure for the partnership to stand side by side with Health Action International, Rutgers, MSI, and
We apologize. We need you to put your microphone in front of your mouth, otherwise we cannot interpret. Thank you. I apologize.
Sorry. So thank you. And it is a great pleasure for the partnership to be with all of you here today. Colleagues, I have, very detailed prepared notes, but what I wanted to do this morning, and with the opportunity here to share some reflections with you, is to share it in two parts. The first part is to look at the story of promises made but not kept, commitments made but not delivered, and where we are when we do look at what Sharifa, you started us off by saying, in terms of meaningful adolescents and young people's engagement in context of SRHR, and then look at what can we do about it, and where are the solutions, and what do we do in terms of addressing some of these issues. And I would like to come back to looking at it through voice, choice, and the space that we are talking about. So if we do look at where we are, we do have a 30-year-long history of commitments being made, from International Conference on Population and Development to the Beijing Platform of Action, and more reiterations of that through the quinquennial reviews and declarations, MDGs, and the Sustainable Development Goals. And which shows, to be fair, that remarkable progress has been made over the last 30 plus years. We have made progress in terms of reduction of maternal newborn child mortality between 40 and 46% from
environ 46% à ce jour, et nous avons amélioré l'accès à l'éducation.
Commodity, specifically contraception. However, there are challenges that still remain. And challenges not just in terms of health outcomes that remain. We do see plateauing of progress in pretty much every region of the world today. But we are looking at progress being challenged also through some of the other parameters. Shrinking civic space in many countries, where many of the adolescent sexual and reproductive health and rights organization work is a real challenge today to the advocacy, accountability, service delivery work that we want young people organizations to be undertaking. We also know that in many spaces, there is an anti-rights pushback that is now starting to gain hold, which means the work that we are talking about in several countries today is actually criminalized. You go to jail for advocating for these issues. For instance, in certain jurisdictions, advocacy for issues such as safe abortion care or those related to LGBTI rights is criminalized. And as a consequence, we do have an immense crackdown on the ability of organizations to deliver on the services that we are here talking about and the imperative of those that we are talking about. We are, of course, talking within the context of aid cuts and shrinking budgets across the world. But let's be clear, those aid cuts are not happening in an isolation. We were already seeing a plateauing of funding over the years and reducing over the last few years. According to the OECD analysis, there was about a 9% decrease in funding available for family planning, for SRHR, more broadly, about 14% reduction. So now we are in a deep disarray in terms of what's happening and how do we go about it, and in a policy environment that is becoming increasingly restrictive. And then, of course, we also now have to deal with the reinstatement of the global gag rule and the DEI executive orders from United States, which mean that much of what we do is now being shrunk in its ability to deliver on what is required. But what is required for us is, if you do look at the data picture, and allow me to read some statistics for you, which I'm sure this group is very familiar with, but just to recap, pregnancy and childbirth-related complications are the leading cause of death among 15 to 19-year-olds. Every year, 21 million adolescent girls in low and middle-income countries become pregnant, and globally, 1 in 5 girls is formally married or in union before reaching the age of 18. So that's the challenge that we need to address, and the context, as we just talked about. But the sad reality is that we know this is doable because we have been doing it, and we can achieve change. But the change that we have been able to achieve by far has always been limited to change at boutique levels. We haven't been able to go to scale. If you look at the progress in sub-Saharan Africa, for instance, on adolescent sexual and reproductive health outcomes over the last few decades, adolescent fertility rate has indeed fallen from 126 to 103 at present. Child marriage, as defined, is also declined. The challenge that we therefore today have is, how do we take it to scale, and what would that entail from not only this room and audience online, but the collective community of us working on sexual and reproductive health and rights. So to go back to that, I do want to start with a bit of a clarity. We are not talking about a passive recipient group here. When we talk about MI, or the meaningful adolescent young people engagement, they are the active agents of change. They are the leaders. They are the ones driving the change, and they need to be at the forefront for everything that we do. It is challenging because of the spaces that I talked about, the spaces such as, the ones that we are operating in within the context of United Nations, the World Health Organizations, which are all shrinking in its ability to deliver on the sort of change that we are talking about. So what do we do? 3 things before to suggest, and I go back to my typology of voice, choice, and spaces. The first I would want to come to is how do we move it from tokenism to transformation? And if we are going to do that, we do need to talk about not just consultations, we do need to talk about co-creation, co-governance, and co-leading these agendas with the young people at the forefront. And it's not easy. A few years back, the Partnership for Maternal, Newborn, and Child Health led the Global Forum of Adolescents and What Young People Want agenda, consulting with 1.5 million people around the world. And the message that we got was very clear. We don't really need your permission to lead. What we need is the space, we need solidarity, and what we need is sustained support. So the challenge for us is, what are we doing about it, and how are we going to be able to deliver on that demand from our young colleagues around the world? The second is, how are we going to address the anti-rights, anti-SRHR pushback? It's not neutral. It is intentional to silence the voices, particularly of those young women, girls, LGBTI communities, and to take away their choices, their bodily autonomy, and their futures. That is why partnerships such as those joining today are vital, because we are not bound by political cycles. We are bound by a shared commitment to those young people and to their futures and to sexual and reproductive health and rights for all. But that requires courage in this environment. That requires us to stay together, work together, when every instinct is going to tell us to be pulled apart. Because when funding becomes transactional, choices will have to be made, whether we are going to be led by values or we are going to be led by sustaining our careers, our futures, our jobs, and our salaries. The last point I want to make is we do need to bring an intersectional approach to what we are talking about. Adolescents don't lead single-issue lives. Adolescent sexual and reproductive health and rights are dependent on a plethora of other issues. These are realities shaped by intersections of patriarchy, climate injustice, economic precarity, digital harms, and systemic discrimination. Our collective responses, therefore, must reflect on that complexity. It must be designed with, by, and foremost by the marginalized of these adolescent groups. It's not a homogeneous group that we are talking about. The heterogeneity includes those with disability, those living in conflict, those with diverse gender identities, those with indigenous backgrounds. To be inclusive, they need to be part of this journey as well. And in closing, I want us to just urge you to recommit with humility to doing what we can to ensure that adolescents today are not left behind. Thank you.
Thank you very much, Mr. Rajat. I think I could definitely listen to you all day long. But one of the key things I just want to reiterate what Mr. Rajat just said, young people do not need the older generation's permission to lead. What they need is collaboration. They need sustained efforts, sustained partnerships, sustained support. That is how we are able to shape the future, not by having a seat at the table, but the opportunity to shape the table. With that being said, we have a beautiful, Alex? Right, we have a short video that we want to share with you from all our partners. We hope you enjoy it.
It is important for my community to continue receiving funds for SRHR because it has proven to be a game changer and it has proven effective in addressing adolescent sexual and reproductive health. Continuously, we're also seeing a change in the community norms that were barriers for young people to access sexual and reproductive health and rights. And therefore, with the continued funding towards adolescent sexual and reproductive health, more young people will be able to access these essential services.
Projects such as the SHARP project continue receiving funding as it supports adolescent sexual and reproductive health. This does not only benefit communities, but also prevents young girls from getting teenage pregnancies. And it is through such projects that we're able to facilitate for accessible, affordable, and available commodities for sexual reproductive health for young people in Zambia.
Il est crucial de continuer à financer la santé sexuelle et reproductive des adolescents et des jeunes, car c'est un pilier de leur avenir. Le financement permet d'accès à l'information, aux soins et à un accompagnement adapté à leurs besoins spécifiques. Sans ce soutien, de nombreux jeunes restent exposés à des risques évitables comme des grossesses précoces et des infections sexuellement transmissibles.
It is very pitiful to see our young girls, teenagers especially, be pregnant on streets. Our young boys abandon classes, but financing our project and sustaining advocacy and sensitizing our youth change a lot in our community. Therefore, I advocate everyone to engage themselves, to support us, to see the change that we want in our society, particularly in my community in Togo.
Grâce à votre financement, j'ai pu participer à des sensibilisations et des implications qui m'ont permis en fait de parler librement et sans tabou de ma santé sexuelle et reproductive. Et je souhaiterais que, bien sûr, grâce à votre financement, d'autres jeunes comme moi puissent en bénéficier afin qu'ils puissent prendre des décisions libres, sûres et sécuritaires de leur santé sexuelle et reproductive.
Before being trained, we were taking the education tackling on SRHR as taboo. Now we are educating our young people on SRHR. So those funds that will be received will be helping us to empower us more and even empowering our faith leaders on how they can promote SRHR in their faith communities.
I have been a beneficiary of sexual reproductive health at a very young age, at the age of 15. And I have seen the benefits that this has brought me. It has made me have informed decisions on my sexual rights and on my body. Furthermore, if we are to achieve the universal health coverage, leaving no one behind, it means that we need to bring adolescents on board. And this means that adolescents should be able to access services without discrimination. So funding needs to continue for the sake of the future.
Il est crucial que le Cameroun continue de recevoir des financements pour soutenir la santé sexuelle et reproductive des jeunes et des adolescents qui représentent plus de 50% de sa population, car ces jeunes sont confrontés à plusieurs défis notamment. Ces financements pourraient donc contribuer à la réduction des effets de tous ces défis, car investir sur la santé de la jeunesse, c'est investir pour le développement et l'avenir d'un pays.
Voices. Those are the voices from our programs. As you can see, we didn't just target young people, we targeted policymakers, faith leaders, and they all responded to the question around why funding for ASRH is important, why is continued funding crucial to maintain, sustain, and also scale up the progress that we have made over the past couple of years. With that being said, I would like to invite my panelists to the stage. For the first, we have Hayat Ayeva. She's an SRHR activist at Rutgers Ensemble from Togo, and she'll be joining us online. Hayat? Thank you very much.
Hello, everyone. Good morning. Thank you, Sharifa.
Our second speaker is Ms. Sarah Ketchen. She's the SRHR advisor for My Health, My Rights from Plan International. Yes. A round of applause, please. We also have with us Ms. Wilhelmina Celestine, Youth for Health Project Lead, MSI Tanzania. If you could, yeah. Second? No. Yeah. Sarah? Okay, it's okay. And then finally, we have Dr. Tim Reed, Executive Director for Health Action International. Yes. As we're about to start today's panel discussion, if you have any questions, this is specifically for our online audience. We have activated the Q&A button. You can leave your questions in the question and answer box. For the people in the room, please do note down your questions. There's a lot of information, a lot of amazing lessons that we are about to share, or at least they are about to share. And yes. Okay. I can hear myself. All right, good. Right, so thank you very much for joining us today, Hayat, for making time to join us this early morning. Each of these speakers will speak on their projects. They are all from the 4 partners that form up the EU project. And Hayat will be speaking on Adolescent Ensemble. Hayat, as a young person, what are some of the biggest hurdles you face as an adolescent in accessing SRHR services in Togo? But before you answer, if you could briefly tell us what you did with Adolescent Ensemble, that would be great. Thank you.
Okay, thank you, Sharifa. I would like to express myself in French. So put your headphone, please. Merci beaucoup à Sherifa. Bonjour tout le monde. Mesdames et messieurs, honorables invités, tout protocole respecté. Bonjour encore une fois. Alors, avec Ado Avance Ensemble, nous avons beaucoup travaillé en matière de renforcement de capacité. En tant que jeune activiste, j'ai été renforcée en matière de santé sexuelle et reproductive. Et nous avons formé le consortium et nous travaillons aussi avec les jeunes du mouvement d'action des jeunes de chaque association membre de IPPF. Alors, mesdames et messieurs, ce que je m'en vais vous dire va certainement vous choquer. Alors, savez-vous que de nombreuses adolescentes et jeunes filles utilisent du sable, des sachets plastiques, des papiers pour retenir le sang de leur menstruation? Et ce qui conduit à quoi? À une mauvaise hygiène menstruelle et donc à des infections liées au sexe. Et ce n'est pas seulement le problème de précarité menstruelle. Il y a aussi le cas des grossesses précoces en milieu scolaire comme extrascolaire, les grossesses non désirées, les avortements clandestins, le manque d'informations claires et de qualité en ce qui concerne leur santé sexuelle et reproductive. Ces jeunes-là ont des besoins spécifiques, mais manquent vraiment de soins adaptés pour pallier à leurs problèmes. Ce qui nous emmène à être confrontés à plusieurs défis. Vous allez constater qu'il y a la méconnaissance des services de santé sexuelle et reproductive par leurs jeunes. Il y a l'absence d'indication et les services proposés, les tarifs également proposés par les établissements de santé ne permettent pas aux jeunes de pouvoir y avoir accès pleinement. Il faut noter aussi l'accessibilité financière. Je dirais dans ce sens que les services sont rarement autant pour moi gratuits, même dans les pays où le gouvernement exige la gratuité des services de santé sexuelle et reproductive pour les jeunes. Et l'alternative aussi consiste à ne pas recourir aux services ou à rechercher les options moins coûteuses, mais moins sûres en dehors du système de santé. Je veux parler par exemple de l'automédication. Vu que dans notre communauté, et particulièrement en Afrique de l'Ouest et du Centre, la sexualité étant tabou, lorsqu'un jeune a un problème de santé lié à son sexe, c'est vraiment difficile pour lui de pouvoir se diriger dans une formation sanitaire puisque il se dira qu'il sera stigmatisé et autres. Donc, il préfère rester chez lui et faire de l'automédication et donc acheter des produits auprès des vendeurs ambulants et ce qui coûte vraiment un problème en matière de santé sexuelle et reproductive. Il faut dire aussi qu'il existe encore beaucoup de stigmatisation, comme je le disais aussi tantôt, de peur et de honte liées à l'accès aux services de santé sexuelle et reproductive. Par exemple, les contraceptifs, les dépistages du VIH. Lorsque tu viens à l'hôpital, certains prestataires de santé te disent, ben, toi, en tant que jeune, je ne sais pas ce que tu cherches ici, pourquoi est-ce que tu viens chercher ce produit contraceptif, c'est pour les adultes. Pourtant, il y a une étude même au Togo qui a démontré que l'âge moyen des rapports sexuels au Togo est de 15 ans. Ce qui veut dire que les jeunes, même qui ont un âge inférieur à 15 ans, sont déjà sexuellement actifs. Et nous voyons même dans les CHU, dans les formations sanitaires, des jeunes de 9 ans, de 10 ans qui sont déjà enceintes et ce qui cause vraiment des problèmes spécifiques et ce qui amène les jeunes à pouvoir faire l'avortement clandestin. Les jeunes en fait craignent de se voir refuser ces services en raison de leur âge ou de leur situation matrimoniale ou peur de rencontrer quelqu'un qu'ils connaissent en attendant leur rendez-vous à la clinique. Parce que le jeune se dira, ben, écoute, il se peut que mon oncle ou bien un tonton du quartier s'y trouve. Et ça ne serait vraiment pas bien que je puisse y aller. Et lorsque nous allons nous croiser, il pourra toutefois aller dire à mes parents que je suis venue pour adopter une méthode de contraception. Il faut dire aussi que la mauvaise qualité des services peut dissuader les jeunes d'y avoir recours. Par exemple, les rumeurs qui tournent autour des méthodes contraceptives. Nous avons entendu dire que les méthodes contraceptives conduisent à la stérilité. Les méthodes contraceptives, ça vient de l'Occident et c'est vraiment pour limiter les naissances. Les méthodes contraceptives te donnera assez de mots de tête. Vous voyez une panoplie vraiment de rumeurs qui tournent autour des services de santé sexuelle et reproductive, ce qui empêche vraiment les jeunes de pouvoir y accéder convenablement. Mais avec Ado Avance Ensemble, nous avons beaucoup travaillé là-dessus et je pense que je reviendrai. Sherifa, c'était mon intervention pour répondre à ta question liée aux défis, aux problèmes auxquels les jeunes sont confrontés. Merci à toi.
Details, and I really hope you understood how detailed she described the hurdles. Sarah, you have worked extensively on breaking taboos and reaching vulnerable adolescents with sexuality education. The young person has spoken. There's a lot of challenges around access to education. There is stigma, there is shame. Tell us what you did with your innovative approach to CSE, and what is the difference between regular CSE programs and then what you did with the amazing CSE activity cards. You could also give us maybe 2 lines on what the CSE activity cards were. Okay. Yeah.
Thank you very much, Sherifa. Yeah, good morning, everyone, and welcome. My Health, My Right project is a project that is implemented in 6 countries in West Africa. And in this project, we hope to advance sexual reproductive health and rights for adolescents and young people. And this program focuses on 2 main approaches, promoting CSE, comprehensive sexuality education for in and out of school adolescents, and linking it with the provision of age and gender responsive services at the health facilities. That being said, in this, the approach we use to make sure that comprehensive sexuality education is provided to out-of-school adolescents, we are using Plan International resources we call CSE activity cards. These activity cards are a set of cards that have been rolled out with adolescents and young people to make sure that they have correct information on sexuality education. And it is adapted for all age groups. And these cards have peculiarities. The first one is that it offers comprehensive information. What do we mean by this? Is that we ensure that the activity cards cover all 7 key international topics recognized for CSE, such as relationship, understanding gender, values, sexuality and rights, human body development. And we make sure that these topics are developed in a logical sequence to make sure young people have the appropriate information. And the information given in these cards are also scientifically accurate with evidence-based information to make sure that they have what they need. Also, the cards are developed in a way that is gender transformative. What do we mean by this? The activities in these cards ensure that young people, both boys and girls, are able to understand and address certain gender and social norms related to sexuality, and that they're able to have correct information. And most especially ensuring that young boys also participate in these sessions so that they embrace positive masculinity and support some of the things that they go through in their communities. And especially in areas where we see a lot of gender-based violence, it begins with young boys understanding how they can work on that, the importance of consent in relationship. And so those are some of the differences that we made. Another key difference with our program or with the CSE activity card is that the content is adapted for all age groups. So these cards have been developed for 4 different age groups, but for the project, we focus on 3 age groups, those from 9 to 12 years, 12 to 15 years, and 15 years and above. Which means for each topic, each of the 7 key topics I mentioned, the content is different for this age group. For example, if we take a topic, relationship, For the age group 9 to 12, we are looking more of healthy and unhealthy relationships. How can young people identify what some of those signs are in a healthy relationship or an unhealthy relationship? How do they get through that? When we look at the age group 12 to 15, we are looking at identifying and respecting boundaries in relationships. How do you walk around that? How do you respect the opinion of your partner in your relationship? And for the age group 15 to 18 years, we look at managing power, control, and cohesion in relationships. So you see, it's the same topic, but the content is adapted for the different age group based on their developmental needs. And the third difference is the methodology of this. We make sure that the activities in these cards are short, fun, engaging. Short sessions, 60 to 90 minutes. And we don't only roll out these activities just to give information like a normal SRHR information session would do, but we make sure that it is learner-centered. It means the young people are engaged in the different activities. We make sure that we give them the information so that they can make informed choices, and we don't just tell them what to do, making them to think critically, reflect on some social norms, and make these decisions based on the information we give them. We don't just tell them, oh, you have to do this to prevent pregnancy, you need to use condoms. We tell you, yes, it's good, but you need to think, you need to reflect. And that way, that is what makes our program different. And another thing is the sessions are rolled out in such a way that we have quizzes at the end to test information, to test if they've been able to capture something, and they ask questions. And so these are the three key differences in our CSC activity cards and the approach we use. This can be used both in and out of school, and it's easy to use by peer educators, teachers, social workers, fun activities, and all of that. Thank you very much.
Thank you very much. Thank you very much. That's very extensive. Talk about drilling the knowledge into the brains of young people, right? There's no escape if you go through the CSC activity cards. When Mr. Rajat was speaking earlier on, he did mention the rise of anti-groups, anti-CSC groups. And I think one of the key challenges or the key things that anti-groups highlight is, oh, CSC is not age appropriate. Oh, CSC is about to take our children from age 6 and tell them you can go ahead and have sex, which is clearly not the case. Another attack point is usually service providers. And coming from a country where MSI has really gone through it, I would move to Ms. Wilhelmina. You have worked especially within rural Tanzania, and you have done an amazing job ensuring quality and adolescent responsive sexual and reproductive health services. When you look at your project, which is the Youth for Health project, what were the main barriers you identified at health facilities that were stopping adolescents from accessing services, and how did you address these challenges? You could also give a line or two about what the Youth for Health project is.
Thank you, Sharifa. Yeah, welcome all to our session. My name is Wilhelmina. I've been introduced. And I work with MSI. For those who don't know MSI, it's a global organization which provides SRH services. We're in around 36 countries, but under the Y4H project, which was the youth focus project, was implemented in 6 countries in Africa. And I'll give more detail about what we did in Tanzania. So the Youth Voice project have been implemented for like 3 years now, and we work in partnership with other 2 organizations called Sikika and SW. And so when it started, we were to design the interventions that goes with our context. And as MSI, we are service provider oriented. We started by identifying what was the gap that existed in the public system. And we also agreed to go with the health system strengthening model so that we can see some sustainability at the end of the project. So we work with the Ministry of Health, but also other relevant ministries, first to identify the region that we can go and implement. In Morogoro region was the region that was selected, and it's because it has a very high teen pregnancy, standing at around 28, while the national average is 22. So we selected some facilities that we could engage, which are public facilities, and then we did some assessment. So what my colleagues have shared from the community level of Togo, the adolescents face the same challenges, but we were focusing in the facility now to see the quality of care that are provided. So we did some assessment and identify a number of barriers at those facilities, from commodities. They had a lot of commodity stock out from time to time, the capacity of the provider, but also their attitude toward adolescent accessing services, but also the quality of services, looking at the infrastructure, the space, because most of these facilities are in rural areas, and even it is like a 2-3 room building. So to have a 1 room dedicated for adolescent services, it's impossible because that facility provides a range of services. So we designed our intervention based on what was the gaps. We started by training the provider. We gave them a number of training from how to give a youth-friendly services in their setup, but also we did some VCAT training. VCAT is the Value Clarification and Attitude Transformation Training, whereby they get to share how they feel about reaching or providing services to the adolescent, and also how important it is. But also we look at other aspects of the infrastructure. We didn't go and build another space or another building, but we improvise. So we agreed with the provider we can have a dedicated time for them to be able to provide services to the adolescent. Because yes, adolescents are not coming to the facility. It's because they feel like there's no privacy. They feel like they'll meet their aunties. So if they come anytime, it's not possible for them. So there are some facilities that agreed to provide a dedicated time over the weekend, and we called it Youth Weekend Clinics. And we could see now the adolescents are coming in, but others also had a dedicated time on Friday. So for like 2 hours, it's just for adolescents to come in. And all of this improvement at the facility really influenced the adolescents to start coming in. And then we didn't just end up starting all of this and then leave the facilities. We continued doing mentorship, coaching, and the good thing, because we had a full support from the government, our mentor, Milestop's mentor, were coupled with the government mentor, and then we'll keep doing it together, hand in hand, coaching and mentoring the providers that we're training, but also working with the 2 partners that I've mentioned who were working directly in the communities to make sure they clarify those norms, working with the community health workers, peer educators in school and out of school. So after some time, we started seeing some adolescents and young girls and boys coming to the facilities to access services. Thank you.
Thank you very much. Thank you very much. I'd like to actually also highlight the importance of making use of the available funds. Like she said, they did not build new infrastructure. And with our current shrinking climate, this is the time for us to become innovative, to do more with less. So hashtag do more with less. If you're tweeting, add that hashtag. Now to Tim, Dr. Tim Reed. You are with the policymakers. I think your questions are going to be a bit more technical, a bit more difficult. So I'm going to put you on the spot. You have worked also on the SHARP project. So for reference, SHARP is the Supporting Healthy Adolescents and Rights Protection. And I would like to ask you, what were some of the key findings of your research? Because you do a lot of evidence-based research to back the work that you do with your partners. What are some of the key findings of your researches, and how has these evidences been used to advance ASRH?
Thank you, thank you. And I'd just like to say how nice it is to be the token male on the panel, which is a welcome change. So congratulations to all. So just to back up a little bit, because Health Action International, we've been around the block. In fact, we go back 15 years, I think. So, and we always start with evidence. We always start with solid research. And there's a little brochure floating around, and this is our strap now, Evidence Advocacy Change. So our entry point is usually medicines and commodities. So what are we talking about here? Commodities for sexual reproductive health and rights. We're talking about family planning primarily. So in the 6 countries in which we work, the first thing to do is to look at the price, availability, and affordability of those products? Are they actually there and available? And the results are variable. In some countries, yes, in some countries, no. But on the whole, we found that they are available. So what's the issue? If it's not supply, it's demand. It can be, of course, in that supply chain, it can be that the centers are not accessible to use, for example, and to adolescents because of stigma or so on. But it comes back to stigma, and it comes back to the social and political context of the country in which our implementing partners are working. Just as a sidebar, we don't do this. Our implementing partners, our adolescent groups, and the people that we work with in country are the ones that do this. So what happens then is that this published research, and there's a few around, but in all 6 countries, we looked at the availability. So what's the problem? So we interviewed adolescents. We interviewed adolescents about access to sexual and reproductive health commodities. And then we researched or interviewed healthcare workers about their attitudes. Now, then you got a whole body of research, and like, well, I used to be an academic, so it doesn't stop with the research, right? It should never stop with the research. That has to be converted. And this is converted through a multi-stakeholder engagement platform. They might be existing platforms, they might be technical working groups by any other name, a multi-stakeholder engagement. Through those platforms, supporting the government in their attitude, and to acknowledge Dr. Anani again, welcome, in Burundi, supporting the government on the implementation of their policies. But you actually asked me what the findings were. So I think I've answered that one.
Yes.
Yeah?
You have.
Okay.
Right. Thank you very much. Hayat, are you still with us?
Yes, I'm here.
Very good. So I would like you to briefly tell us, as a young person, also drawing from your own experiences and other experiences around with people around you in Togo, what has been your role in trying to overcome the hurdles you mentioned before and improving the situation for other young people? Briefly.
Merci beaucoup, Sherifa. Alors, en tant qu'activiste sur les droits humains, en particulier les questions liées à la santé sexuelle et reproductive des adolescents et des jeunes, j'ai joué un rôle, en tout cas très important, surtout en déconstruisant les mythes liés à la sexualité. Parce que ce que nous faisons, la plupart pensent que non, nous sommes des sexologues et que nous voulons conduire les jeunes à une vie de débauche à travers l'information que nous venons donner, mais ce n'est vraiment pas ça. Je suis sûre qu'un jeune aujourd'hui qui a en tout cas des informations claires et de qualité en matière d'éducation sexuelle complète, retarde d'abord ses premiers rapports sexuels et ne va même pas être confronté à des problèmes que j'ai eu à citer, à savoir les grossesses précoces, non désirées, surtout les avortements clandestins. Et donc, personnellement, en tant qu'activiste, je travaille beaucoup sur des contenus qui me permettent en tout cas de sensibiliser les jeunes. Ce qui fait que vous allez voir, chaque jour dans mon inbox WhatsApp, je reçois beaucoup de messages des jeunes en lien avec la sexualité. C'est soit il a un bobo sur son sexe et qu'il a des difficultés à aller dans un centre de santé et me demande de lui référer, par exemple. Ou vous allez voir des jeunes adolescentes qui sont enceintes et n'ont qu'à l'idée d'avorter, de pouvoir pratiquer l'avortement. Et vous imaginez si ces jeunes-là n'ont pas accès à ce droit à l'avortement sécurisé, ils iront pratiquer l'avortement clandestin. Et la plupart du temps, ces jeunes-là, vous allez les voir utiliser, excusez-moi, des méthodes inadmissibles pour pouvoir se faire avorter. Hein, des tiges de manioc, des biques. Lorsqu'on côtoie vraiment les jeunes sur le terrain, surtout celles vulnérables, on comprend que les jeunes ont des besoins particuliers en matière de santé sexuelle et reproductive. Et afin d'améliorer l'adaptation de ces services de santé sexuelle et reproductive, Ado avance ensemble à veiller à ce que les adolescentes et jeunes eux-mêmes, membres du mouvement d'action des jeunes auquel j'appartiens, soient impliqués de manière significative dans l'amélioration de la prestation des services. Et c'est du début, lorsque je parle de l'implication significative, c'est du début jusqu'à la fin. De la conception de l'idée, en passant par la mise en œuvre jusqu'au suivi, évaluation. Et ce qui est très intéressant, nous faisons partie, en tout cas, de la trajectoire en matière d'éducation sexuelle complète. Cela nous a permis, en tout cas, de renforcer nos capacités et nous avons eu à sensibiliser sur le terrain, à former sur le terrain les directeurs régionaux de l'éducation, les inspecteurs, les directeurs régionaux de la santé et même des prestataires de services. Et plus spécifiquement, nous, en tant que jeunes du mouvement d'action des jeunes, nous avons participé à la formation des prestataires de soins de santé sur la prestation de services de SSR adaptés aux jeunes. Nous avons pris part à la clarification des valeurs. Nous sommes devenus aujourd'hui des formateurs en matière de clarification des valeurs sur l'avortement. Nous avons également appris à faire du counseling, donc pratiquer vraiment des conseils sans stigmatisation, sans discrimination liée au genre ou à l'adolescente. Nous avons aussi évalué l'adaptation des services offerts par les formations sanitaires à la jeunesse et accompagner aussi ces différentes formations sanitaires dans l'amélioration de leurs prestations de services à travers un outil que nous utilisons aujourd'hui quotidiennement et nous faisons vraiment des partages d'expériences à travers les pays du consortium. Les jeunes ont aussi contribué à orienter d'autres jeunes vers des services tant par le biais d'activités communautaires en présentiel face à face, à travers des sessions d'éducation sexuelle, des visites à domicile, des porte-à-porte. Et nous avons aussi initié des activités en ligne avec la gestion du centre d'appel ou du chat en ligne. Par exemple, nous avons mis en place l'application Info Ado Jeunes que vous pourrez toutefois aujourd'hui retrouver sur Play Store. Et cette application offre une panoplie de choses en matière de santé sexuelle et reproductive pour les jeunes, bien sûr, qui ont un accès à Internet. Et à travers cette application, nous faisons de la téléconsultation, nous faisons le suivi du cycle menstruel. Il y a des conseillers également qui sont connectés 24 heures sur 24 et qui répondent aux questions des jeunes. Il y a aussi la ligne verte, aussi mise en place, une ligne à travers laquelle les jeunes peuvent toutefois appeler gratuitement et pouvoir poser leurs problèmes exacts. Donc, voilà ainsi les activités que nous avons eu vraiment à mener, notre contribution aussi en tant que jeunes. Il faut dire qu'à la moitié de sa troisième et dernière année, le programme Ado Avance Ensemble a formé plus de 26 000, autant pour moi, personnels médicaux et non médicaux sur leur capacité à offrir des services adaptés de manière non stigmatisante pour les adolescentes et jeunes dans les 5 pays de mise en œuvre qui forment le consortium. Et à travers ce programme
I think you've gotten very passionate again.
Thank you. Donc, à travers...
Sherifa,
please, nous avons... OK. Je voudrais dire également que ce ne sont en tout cas pas des chiffres. Ce sont vraiment des grossesses précoces évitées, des avortements clandestins évités. Et ce sont des vies améliorées pour les adolescentes et les jeunes qui méritent d'avoir d'accès aux informations. Et je pense que vous retrouverez les codes QR de Rutgers là-bas que vous pourrez toutefois aussi scanner, puisque actuellement, Rutgers travaille sur un programme de recherche à l'avortement sécurisant dans les pays de Ado Avance Ensemble. Merci beaucoup, c'est très passionnant que je parle sans savoir que je ne suis plus.
Thank you very much, Hayat. I think there's just so much knowledge, so much lessons, and so much content. And we will share the QR codes. You can read more into the projects after the session. Sarah, what challenges did you encounter introducing this different approach? And I'd really like to ask that you keep it brief as you can.
Of course, I will. There is no approach without its hurdles, even though the outcome is good, but some of the challenges we face so far with this is the practical part of it. You remember earlier I said the difference between our CSC sessions and SRHR awareness sessions is that CSC, we cover 7 topics consecutively in a logical manner, whereas SRHR information is a one go. We go at once, we provide the information and we stop there. So the practical challenge of retaining the adolescents for each session was really a domus, because you need to make sure that they always come to the site, they have permission from their parents to attend and all of that. So it was a big challenge, even though we managed to go around that. Another aspect is capacity challenge. This is a new approach even for plant staffs and for the community that always used to doing the awareness raising sessions, doing flyers and all of that. But this one actually requires you sit with the young people, you roll out activities, you converse with them and enable them to make that decision. And so building the capacity of these facilitators has not been easy. And the cuts are easy in such a way that we work with social workers, teachers, parents, peer educators. And so we need to continuously support them to be able to roll out these sessions and for them to be able to answer to the questions. And so that is a challenge. And also the fact that some of these activities require that the facilitators themselves work on their values. You remember one of the key aspects I said is we give scientifically correct information. So you have to make sure as a facilitator, your personal values don't come in between giving the correct information to the young people. And so this training, we need to make sure that we have good facilitators who can actually do this without their personal values intervening. And another challenge is concerns and fear for the community, from the parents, from the community leaders, the religious leaders, even the government, where they usually confuse CSC for us promoting early sexual debut for adolescents. And so these are some of the challenges we face, and I'm sure I will tell you how we overcame these challenges in the subsequent sessions. Thank you very much.
And if you are a bit impatient, you can also keep in mind that the QR codes will also be shared. They are also on the leaflet that has been handed to each and every one of you. We are at a point where we should be taking Q&As, but I can't do that without hearing from Wilhelmina and Tim. To Wilhelmina, your project is amazing, like all the other 3 projects. Tell me, what have you achieved the most impact on, and what are you the most proud of?
Thank you. That's a very good question, because I'm proud of many things that we achieved, but I will just highlight a few. And first of all was the adolescent accessing services. Because of course that's the end result that we were expecting. It's always sad if you cook food and nobody comes and eat, right? Yeah, so we were trying to improve the quality of care in these facilities so that the adolescents can come in and access services. And I'm sure no one wants to access services that are poor. So good quality of services always attract people to come. And we started seeing some numbers of adolescents coming to access services. And in 2 years of the implementation, we were able to save around 16,000 adolescents. And we were so proud to see that these young girls and boys are now even confident to come in the facility and access services. And I'm not just telling this passionately just because I work under MSI. I grew up in the rural of Tanzania, and I lost some classmates when I was 14, 15 who died with unsafe abortion. So it's real. It's real back there. So when we do all of these interventions and you see that they are confident now to come and access services, it is something that you get proud of. And another thing that also where it was amazed, it was the collaboration between us, CSOs at the local level, but also the government. We received a lot of support from the government, and the regional level, they were they were also positive on what we are going to do because it's one of their indicators, and they were failing in that indicator somehow. So there was a lot of support from the government that made our work easier. And even when we were doing the mentorship, you could see that decision maker, government staff were also supporting in a day-to-day basis. But one last achievement was the allocation of budget in the facilities. When we started the implementation, there was zero budget allocated for adolescent services, zero, nothing in the facility. And this budget are developed in the facilities. But when we started advocating for the budget allocation with the partner that we were working with, you could start seeing some little number. Of course, it's little, but with time, it keeps growing. And we assure that even when the projects end, there's something that will keep going even with or without us. So those are the most three important things that I can highlight.
Thank you very much. Talk about ownership. So one tip then, if you want to get your government to take ownership, involve them, let them have an indicator in their budgets and hope that they are failing. That way, you can get to push them to put money, because when sometimes they put it there, they don't allocate budget for it, right? But then when they're there, you're there to hold them accountable. Hey, you have this in your indicators. It's a good way to lobby for funding. Thank you very much for sharing. Tim, you mentioned earlier on about the relevance of multi-stakeholder partnerships. I want to ask you, how has SHARP contributed in building or strengthening these multi-stakeholder partnerships, and what makes the approach unique and effective?
Briefly. Yeah, I knew. Not only the only male, I'm the last one. So my civil society space has been shrinking. So with apologies to the interpreters and acknowledging their presence, I'm going to speak quickly, right? So we have our research, we have our basis on which we can move forward in a multi-stakeholder engagement. Historically, when we were doing access to medicines, access to insulin, it would be private sector, public sector, and civil society. What's unique about this project is the engagement with faith leaders in that multi-stakeholder engagement. And it's been amazing. I mean, I've been stunned at, like I was saying earlier, actually, maybe I didn't, but I meant to, policymakers actually know what they want to do. They know where they want to go. Actually, so do faith leaders. They're getting young women come to them at 13, 14 who are pregnant. They know that they need to step up. They needed the space and they needed the evidence. And as we saw earlier, it's most extraordinary that this was an Anglican, I think, could be Catholic, priest from Zambia, actually stepping up to the, what?
Rwanda.
From Rwanda, stepping up to the plate. And I just think that's amazing that these multi-stakeholder groups, driven by our country partners, driven by the voice of adolescents, and the governments hand in hand, are actually making a difference. Now, in terms of policy change, we have over 30 now policy changes which have enabled budgetary change, enabled the establishment of safe spaces in schools, enabled safe spaces in healthcare clinics, raised awareness, I think, about making them youth-friendly. In other words, let's not have a front door with a big sign out on the high street. Let's go around the back and get rid of that. So those sorts of things have really come, and that it's different in every country because the youth in every country operate in different contexts. And I think that's one of the wins as well, is the ownership of the spaces by all the stakeholders that are engaged in them. That answers your question, I hope, and it was brief.
Yes, it was. Thank you very much. I think we can do better for the 4 EU-funded projects. It's amazing what you've done. So I would like to ask for another round of applause for all of them. At this point, I'm going to pause and look into the room for questions. Okay, I see one hand in the back. Okay. So for the online, we will get to you also to pick some questions from the online group as well. If you have not submitted your questions, please do in the Q&A box. If your question has been answered, that will be good. But if it's not answered yet, so yeah, at the back. And before you start, please mention your name, organization, or affiliation as well.
Perfect. Hi, everyone. I'm Nihal Saeed. I'm at IPPF, the International Planned Parenthood Federation. I think my question is primarily for Sharp, but also for others, and I would love to hear Hayat's sort of perspective on that. Is the role of pharmacies, and I know that increasingly, at least in the youth, sort of youth-centered, youth-responsive sort of services, we want to do more work with pharmacies. They know that they're also gatekeepers for the services. They could be the ones really the first contact with young people, not necessarily be it the clinics. So I wanted to understand if there has been interventions with pharmacies on these issues. My other question is really around the potential of self-care. Yesterday we've been talking a lot about self-care, and I think Hayat did touch a little bit around it. You know, like the self administration of medical abortion sort of products and other sort of issues. So sort of just getting your sense around the potential of self-care for responsive services. Thank you.
Thank you very much. We will start with your first question. Dr. Chandra also has a question, and we'll take a round of questions, and then the panelists will answer. Then we can move on to the online group.
Hi, good morning all, and fantastic panel. Thank you very much. I worked in WHO for 30 years. I retired from WHO. I continue to work on adolescent sexual and reproductive health and rights on my time and my terms. So on Sunday evening, there was a wonderful panel here, doing more with less. And the one of the Ministry of Health officials from Malawi said, we sometimes get people coming into our country and telling us what they want to do. We engage with them. We say, perhaps you should do something different. They rarely take our points of view. And as beggars, we can't be choosers. How do you get, I'd like you to respond to her. How do you get donors to engage with government, advocate with government, dialogue with government, but not walk over government? Thank you.
That's a very pregnant question, but very also vital. Do we have to take one more? All right, you have to choose.
Good morning, everyone. I'm such a wonderful panel, by the way. I'm so inspired, and it's just, yeah. So my colleagues and I are actually from the University of Southern California. We're all Masters of Public Health students. Specifically, my concentration is in global health. So being in Geneva, I have a paper in mind, and mine is specifically on my region of Ethiopia called Tigray. So I'm Tigrayan and Egyptian, but so I'm not sure if anyone is knowledgeable, but Tigray was currently involved in a genocide against my own people. And specifically, one of the populations that was extremely affected was women. And we see a lot of sexual violence. We see rape happening with these women. So I've been hearing how we can use the infrastructure that the government already has and revive it. But what if that same infrastructure is used against its own people? So how can we ensure the protection of women and ensure their protection, their sexual rights, their autonomy when the government Thank you. When the government is abusing those rights.
Right, thank you. We can have Tim answer the first question because that was very directed to you.
Thank you. Yes, you're absolutely right, of course. Pharmacies are a crucial, maybe first gatekeeper for commodity. And they would be engaged in this whole multi-stakeholder circus as part of the private sector, probably. But then you have pharmacies in hospitals, you have pharmacies in state clinics, you have unregulated pharmacies, which can have substandard and falsified medicines, and you can have street vendors. So it's a bit of a mess, right? I'd like to, I mean, I may be speaking out of turn here because I'm sort of like the monkey, not the organ grinder. This should be Ange here today, but it's me. That I think for sexual and reproductive health commodities, which in some countries it's illegal to sell to adolescents under 18, for example, actually should be more widely available, and they should be in pubs and clubs and every public toilet and everywhere. So, I mean, that would be a step too far in many countries, and we're not there to take a step too far. We're there to do what the adolescents can in the context of the country that they're working. So I think the engagement of pharmacists is important. How we then subsequently reach the unregulated and street vendors and falsifieds is a little more difficult, but in a different project, we are working with WHO on unregulated markets. So we're bringing in the role of sexual and reproductive health commodities into that project.
Thank you very much. If you have more questions, I think you could also reach out to Plan and MSI on how they do that within their own projects after the session. So for the next question, the second question from Dr. Chandra, how do you work with governments without working over them while getting them to commit?
Is that me? Okay.
I'll have Wilhelmina answer that.
I'm happy to take it.
It's okay. I'll share an experience from Tanzania. So the government of Tanzania have really made a way that partners can also understand their priorities. So we have different technical working groups that happen each quarter where all partners meet with the government, the relevant ministries, and each year they tell to share the government priorities. So as partners, you also, when you are applying for a certain fund, you also have to align with those priorities. You don't just write something from the air, but rather you understand the government priorities and then you write a proposal to a donor. But also you don't commit everything in the proposal. For example, you don't commit where you will be going to which regions, because that needs to be agreed when you are going to present to the government, and then you discuss together. You say, like, I have a project that will be tackling, let's say, adolescents, and then they'll tell you these are the regions that are doing very poorly with the high teen pregnancies and self-abortions, and then you agree together, like, okay, so we'll go into these regions. So they have really developed that modality that partners get to work through their priority rather than coming with your own priorities.
Yeah, wonderful. That's amazing. Thank you very much. I hope that gives us a bit more perspectives on how we can think around our programming also. But I think, yes, governments, you really want to work with governments. You don't want the government turning against you. That's pretty catastrophic. We have a third question. Would you like to take on the third question? Sarah, for the third question. Yeah.
Okay, the third question was how does the government protect women's rights?
Yeah.
I will try. Yeah, but for my project where we implement, we did not really have such aspects, but I think from my experience, now I'm sharing from my experience and not from the program we did on CSE. One way I think we could protect women's rights is community awareness raising. For really, we at the different levels, working with community leaders, working with the different stakeholders, working with women themselves. Because for us as an organization, we believe if we want to protect, for example, women's rights, we need to put them at the center, like capacitating them to be able to denounce some of those acts of violence and also be aware, be more confident, and then work with all other stakeholders to help them prevent that. That's what I can say from my experience, but that was not really our area of intervention.
Wilhelmina, do you want to briefly touch on that?
Yes, I can add a bit more on how the government can support. First, we also need to understand our governments have signed a lot of treaties. And as partners, it's our responsibility to hold them accountable to those treaties that they have signed. So I'll give an example. In my country, we have signed a Maputo Protocol, which allow women to have abortion when there are some cases of rape, incest, and if it endangers a mother's life. But the abortion that is allowed, which is called post-abortion care, is allowed only when it's going to affect the mother's life. So as MSI, we are one among the organizations that are working in collaboration with other organizations to push the government to expand now the access to women who are pregnant, but they have been raped. There's also some incest issues, so that it can give a wider choice for women to do so. So what we can do is that to understand what the government have signed in different treaties, and also hold them accountable so that they can adhere to what they have signed.
Yeah. Thank you very much. I think a little extra 2 cents is evidence-based. So to have the evidence backed with research and make these recommendations to the government, because when it comes to humanitarian context, it can be a bit tricky in addressing SRHR concerns. So yes, thank you very much for that. Blondine, do we have our questions from our online audience?
Yes, we have lots of questions coming in online, already 19 questions. So I'll try and sum them up together and bundle them together. So one is, what challenges have you faced in incorporating and working with and delivering services to vulnerable adolescents, and namely those in hard to reach rural areas and those living with disabilities?
I would have Hayat. Hayat, did you get the question? Yes, so if you could
Yes,
answer that.
yes. Je peux répondre quand même à cette question, hein. Il faut dire que, OK. Il faut dire que nous avons beaucoup, en tout cas, travaillé avec les jeunes en situation de vulnérabilité et voire même les personnes en situation de handicap. Par exemple, le partenaire Ado Avance Ensemble en Côte d'Ivoire a formé les éducateurs et éducatrices de l'Institut national ivoirien pour la promotion des aveugles à dispenser l'éducation sexuelle complète aux jeunes. Il y a aussi la IBF qui a eu à renforcer, à former les pères éducateurs en situation de handicap physique, à dispenser aussi l'éducation sexuelle complète. Il y a eu aussi beaucoup de choses qui ont été faites, surtout en allant vers les communautés vulnérables pour pouvoir leur apporter la bonne information claire et de qualité en ce qui concerne vraiment la santé sexuelle et reproductive. Voilà un peu ce que j'aurais aussi à dire par rapport à cette question. Je n'oublierai pas également le développement des ressources adaptées, par exemple le manuel de l'éducation sexuelle complète en braille et en format audio qui permet vraiment à toute personne de pouvoir y accéder complètement. C'est pour dire que dans notre combat, personne n'est laissé derrière, personne n'est oublié. Merci.
Thank you very much. Leave no one behind. That's a very good way to end on that question, on that note. Blondine?
Another question was, so adolescents are often struggling to have conversations about SRHR with their parents, or they struggle to access SRHR services because of lack of parental consent. So the question is, how have the different programs involved parents in CSC and SRHR service delivery?
I think I'll have Plan take this.
Yes, thank you. I think one of the ways we do is in the program we implemented, we also have a training package for parents that has like the same approach like the CSC activity card. We called it Building Bridges. We are building a bridge so that parents are able to better communicate about sexuality with their younger adolescents. And so in this, our program, we're also able to train parents and other community gatekeepers on how to have these conversations with their young ones. Also, we have a combination of activities which we do, like intergenerational dialogue, which was organized with parents and young people, so that they also talk about some of the social norms, the gender norms, and taboos around sexuality and how they break that to make sure that the parents actually see the need to allow the children access information and age and gender responsive services. We equally work with community and religious leaders through awareness raising sessions, We train them, we give them IEC materials where at the end of the training, they are now the ones who go into the communities and do awareness raising with their other parents, educators, and also within their groups. All of this is to make that environment conducive and encourage participation of young adolescents in our different programs. So that's the approach we used.
Thank you very much. And like we saw earlier on throughout the presentation and also with the videos, how they all spoke about their projects. We are not only focusing on adolescents, we are engaging community leaders, faith-based leaders, as well as parents and other community stakeholders. I cannot take any more questions at this point. But if you want your question answered and you're in the room with us, you can engage with our panelists after we are done. You also have the option to scan the QR codes to each of the 4 projects to learn more. And you can basically follow us on LinkedIn to continue the conversation. I mean, who finishes the conversation at the WHA, right? So moving on, I'd like to ask all 4 of you. We have interesting people online, very interesting people in the room with us. If you have a call to action, and I'm going to start with you, Hayat. In 1 minute, 30 seconds, I'm going to be counting. If you could make one call to action to the leaders.
Merci beaucoup, Sherifa. Alors, moi, je dirais aux acteurs et au gouvernement.
You've not heard my question, Hayat.
Allô?
You've not heard my question. You're very eager.
Vous avez parlé de l'appel à l'action, je pense.
Right. I'm asking if you could make one call of action to the leaders listening to you today, what would it be to ensure youth are truly included in shaping SRHR policies and services? You have 1 minute, 30 seconds. Go.
Super, fantastique. Merci beaucoup. Oui, je disais, je voudrais m'adresser aux acteurs et aux personnes du gouvernement, aux autorités, bien sûr, du gouvernement, en leur posant la question, où êtes-vous et que faites-vous lorsque les jeunes meurent à petit feu à cause du tabou lié à la sexualité? Où êtes-vous lorsque les adolescents, surtout celles vulnérables, continuent d'utiliser du sable pour retenir leur menstruation? Où êtes-vous lorsque les jeunes continuent à faire l'avortement clandestin? Je sais que vous ne dormez pas et que vous faites l'essentiel parce qu'il y a eu des avancées dans les pays. Mais néanmoins, les gouvernements devraient intégrer les besoins spécifiques des adolescents et des jeunes en matière de santé sexuelle et reproductive dans les programmes de formation des prestataires de soins de santé, en incluant de préférence les jeunes dans ces formations, comme nous le faisons à la TBF. Les gouvernements également devraient allouer des budgets spécifiques pour garantir que les services de santé sexuelle et reproductive soient réellement offerts gratuitement aux adolescentes et aux jeunes. Les jeunes aujourd'hui n'ont pas besoin d'être sauvés, mais ils ont besoin vraiment d'espace, d'être écoutés, de la prise en charge, de l'offre gratuite des méthodes de contraception afin de préserver leur santé. Alors, j'ai écrit quelque chose. Je ne sais pas si vous voyez mon écran. Vous voyez mon écran? United for Reproductive Justice.
Yes, we can. But you need to move back a bit. Move back a bit. Yes. Yes.
Together we are doing. Thank you very much.
Thank you very much, Hayat. I think that is a very clear message to the policymakers, to the donors, to the partners in the room and online with us. Yes, justice, reproductive health justice is very crucial. To you, Sarah, based on your experience with the My Health, My Rights, what would you recommend to donors and future SRHR programs? Also 1 minute, 30 seconds.
Thank you. 2 things. The first thing, and very important, integrate CSC and scale up this type of interventions across all programs involving adolescents, whether they're in or out of school. Because we've seen that once this is integrated, if we do economic empowerment programs, livelihood, education, and we want to make sure that young women are actually empowered, we cannot do that without talking about SRHR. And how best do we get that? is to give them the information they need at the time they need it. So integrate CSE in all programs, scale up the use of approaches like the CSE activity cards within adolescents programming, no matter the sector. The second thing, allocate budget. We need to make sure that these interventions are sustainable. We work across all, with all target groups. We need to make sure that the facilitators, the materials, the information, that continually have support to roll out this program. So we need a budget for that. Thank you.
Thank you very much. Over to you, Lemina. You have had experience working with governments, especially the government of Tanzania. What is your specific ask to the government of Tanzania and to international donors and decision makers who are listening to you?
Thank you, Sharifa. I would want you to not close your eyes, but imagine a facility, a dispensary, a lower facility, which is located in a rural setup, somewhere where you've been or you've ever seen even in a movie, but somewhere in a rural where it's the only source of services, it's the only source of health services to the communities. And then also think about young boys and girls and their health and what it would mean for them to access services and be able to live their dreams. Or the girls that keeps to drop out of schools because they go to the facility and there's no commodities. They go to the facilities and then they don't feel confident to access services. And then when you think of that, think what we can do together in collaboration and in partnership, what we can do to ensure the last mile can access quality service, not just about service, it's quality service, so that they can feel confident to go on and access these services. And when you do that, keep allocating, keep thinking them in the priorities, allocating budgets, but also this was just implemented in one region. Tanzania has 42 regions. So it's like, yeah, there's a lot to be done. I am sure not just in Tanzania, even in other parts of the world.
Yeah.
Thank you.
Thank you very much. We need sustained budgeting to scale up and to also maintain. Thank you very much. Tim.
Well, it's no surprise I'm going to follow that theme. All week at the WHO, once we got through the pandemic treaty, what's been the topic of conversation? Money. It's been about money. Not just the US, but the US has given confidence, I think, to governments throughout Europe. So ODA is being cut and cut and cut. So the first thing that I would appeal to donors or to governments is not to waste the investment that they've already made. The investment in setting up this program, Team Europe and the partnerships group, plus all of the effort and energy and joy that has gone into these programs in country and the successes that they have made, to quote, will be lost like tears in the rain. And we can't allow that to happen. So sustained funding. And secondly, and this is a bit of a broader one, give us longer. You know, to have results in 4 years is very, very hard. And I think we need long projects. Our longest project is 9 years, and that's pretty much unheard of on insulin. So I think actually work with the agencies, work with our youth in country when you're constructing even the call for proposals about what can be achieved in that length of time would be my second ask.
Thank you very much. To my panelists, I think the message is clear. Continued investment in adolescents would help us reap the demographic dividend. The return on investment is massive. There is no planet B, and adolescents are probably the ones, not probably, they are the ones that would lead or will be in these rooms a couple of years to come. Investing in them will ensure that they are in those rooms in a few years to come, and we need to ensure that. We cannot stop now. We're just starting. So there's a need for sustained budgeting. There's a need for sustained support. And even in the shrinking space, again, there's an opportunity for us to do so much more with the little that we have. With that being said, I'd like to invite Marika van der Plas, who is the ED for Rutgers, to give us the...
Thank you. Yeah, keep it short, I know. Bonjour, good morning. So many actions, so many stories, so many results. I'm so inspired right now by the panel. Thank you so much. Yes. And these 4 partnerships is really a special day. Partnerships on adolescent sexual and reproductive health and rights. On behalf of the 4 partnerships led by MSI Reproductive Choices, Health Action International, Plan International, Rutgers, proud member of IPPF, and our 28 partners across 16 countries, again impressive, in Africa, I wish to express gratitude to the European Union and in particular its Directorate General International Partnerships for funding the current phase of adolescent SRHR partnerships and for making today's inspiring event possible. I'm also inspired by this audience with a full room and a lot of people online. At one point I saw 100 people online, so that's really good. On this Friday morning. What an amazing turnout. And I wish to thank you all and acknowledge the representatives of the government of Togo and the government of Burundi here in the room with us today and many other high-level representatives. The European Union has recently reaffirmed their commitment to gender equality and to evidence-based, we heard it today, evidence-based decision-making. Together with the Team Europe Initiative member states, you are the champions of a strong commitment to adolescents' sexual and reproductive health and rights, and we commend you for this. But I also want to say that today's gathering is not just a celebration of progress in difficult circumstances, but also of powerful collaboration, sharing, and synergy. This is very key at a time, we already said it, when governments are forced to make difficult decisions, when funding is limited, and there are many competing demands. We are proud of what we have achieved in our 4 partnerships and are very aware of the need to increase efficiency and yes, to do #more with less. But we are also confident because we have good experience and have tested approaches that we can bring to scale at relatively low cost. So today is also a call for action for international partners and donors, because at this very moment, a 15-year-old girl in Benin, out of school and with no access to reliable information or youth-friendly services, may be forced into early marriage or an unwanted pregnancy, simply because she cannot access the knowledge, care and protection she deserves, and there are millions like her. At a time of devastating costs to development aid and pushback on human rights, especially for girls and women, shrinking space for civil society, and attacks on science and the WHO, we must not retreat. We must stand firm together. Therefore, we call on all international partners and donors to uphold their commitment to SRHR and gender equality. These are not optional. These are essential for global health, poverty alleviation, and sustainable development. Second, to keep investing in adolescent SRHR. It's a critical foundation for achieving the SDGs and for supporting the potential of future generations. And thirdly, to champion, support the civil society organizations and young advocates like Hayat here online, ensuring equity, accountability, and access. Let's not step back. For that girl in Benin, and for every young person still waiting for access, equality, and a fair chance at a healthy future, we have to make sure that the last mile is there. So thank you, and I want a big, warm applause to Sharifa for guiding us this morning. Thank you so much. You did a great job. It's like 6 minutes after 10.
Thank you very much, Marika. On this note, I'd like to say a very big thank you to our keynote speaker, Mr. Rajat, and also to our panelists. Thank you all very much for sharing your lessons with us. I would also like to thank the audience in the room and also our lovely audience online. Thank you so much for engaging with us and staying to the very end. Thank you very much, Hayat, for making it possible to join us, because I know you had to go through a lot of struggles to join us online. So thank you very much for joining. At the end of the day, I'd like to leave with a note that for all our partners in here and online, it's important for us to continue advocating, continue the dialogue, and also ensure that we keep ASRH on the agenda. It is not something that should be second guessed. It has to be and has to stay on the agenda moving forward. I know there's been a lot of conversations the past week, but at the end of it all, let's think about in 20 years to come, how do we want the world to be? Who do we want to be leading the world? We want to have young people who are making informed and healthy sexual health decisions and choices. And on that note, thank you all very much for joining today's session. Yeah, that'll be the end of it.